You are not going to have very much trouble identifying a kidney stone in life or in a vignette. The presentation is very classic and very rarely does it present in any other way. So where you need to go in this lecture is, which diagnostic steps do you use in which patient? And then, how do you treat the stone based on size? We'll finish off with the different types of stones that there are and the risk factors that you can modify to reduce the chance of recurrence. I want to take you down the diagnostic pathway, starting with patient presentation to finally being done with the stone. You'll see what I mean in just a minute. The person with a kidney stone is going to present with colicky flank pain. And that pain is going to radiate to the groin. And most patients present with hematuria. These patients, colicky flank pain, radiate to the groin, plus minus hematuria, without fever and without a mass, are likely to be kidney stones. Kidney stones are literally rocks that are in the ureter and they get stuck. The ureters have peristalsis. So every time there's a peristaltic contraction, as it contracts down on that sharp rock, it hurts. Then the wave passes the rock and the pain goes away. With each peristaltic contraction, it's going to hurt again. If it's bad enough, they'll get obstructed, and hydro, causing distension, also hurts. The patient's going to be writhing around. Right? They're not going to find a comfortable position, though they're trying. And because hematuria is so common, about 85% of patients have it, that the first step in the workup of a kidney stone is actually a urinalysis. With each peristaltic contraction, sharp rocks digging into the ureter, there's going to be a little bit of blood. Now, it may not be gross hematuria, but if you have no microscopic hematuria, it probably is not a stone, and you should look for something else. For the purpose of this discussion, let's just say there is microscopic hematuria and stone is still on the table. You've identified the person with the colicky flank pains radiating to the groin. They have microscopic hematuria. The next step is actually a conundrum. I'll write them off to the side. What are your options? A non-con CT scan of the abdomen is by far the best test. For all comers, pick that one. But you'll also see options for ultrasound and KUB. If you have to pick one test, remember, the non-con CT is the gold standard. What you're looking for is either the stone itself. If it's radio opaque, you can actually see it, because CT scans are just x-rays in serial. And you'll be able to identify the stone because most stones are radio opaque. Or you're looking for hydro. And while ultrasound is good for diagnosing hydro, it may miss early hydro, and ultrasound is not good at identifying distal stones. But there will be times where you cannot do a non-con CT. For example, in pregnancy. In pregnancy, the ultrasound is the preferred test. The KUB used to be the test you wanted to do for the same reason the non-con CT is. You wanted to be able to see the stone. But the KUB is not sensitive enough, but it can be used to track disease. That is to say, pick the KUB when you already know there's a kidney stone and you're trying to track resolution. If you have to pick, non-con CT is the right answer. If the non-con CT shows no hydro and no stone, it's something else. But if you see either the stone or hydro, you now have a kidney stone. The management of kidney stones is actually really complex. I'm going to give you the easy takeaway and then do it again the right way. The easy way, what I want you to remember, is less than 5 millimeters and greater than 3 centimeters. Greater than 3 centimeters, there's no way anything that you do is going to work, so it's going to be surgery. You have to actually just cut out the stone. If it's less than 5 millimeters, it's going to pass spontaneously, but these hurt, so you're going to give them intravenous fluids to flush out the stone, and give them pain medications. In between, you need to do something to break it up. And the thing that's used most often is lithotripsy. You put the person in a tub, and then you have ultrasonographic waves pounding on their flank, breaking up the stone, allowing it to pass through the urethra. Easy version. The real version goes more like this. Still less than 5 millimeters. If it's less than 5 millimeters, it's going to pass spontaneously, give them fluids, keep them hydrated, and give them pain meds because it hurts. If it's a little bit bigger, 7 millimeters, you want to use, in addition to fluids and pain meds, medical expulsive therapy. Do something that's going to help the ureters dilate and get the stone out. That is going to be calcium channel blockers, like amlodipine, or alpha blockers, like terazosin. So you might see a woman on BPH meds, terazosin, doxazosin, because of a kidney stone. If it's greater than 1.5 centimeters, it's too big and you're going to need surgery. The surgery generally goes like this. If it's proximal, you're actually going to need to cut them. This is a laparoscopic surgery used much more often than open. If it's distal, you can use PAN, percutaneous anterograde nephrolyotomy. And in between, you need to do something to break it up, hoping that it will pass spontaneously. For proximal stones, that's lithotripsy. For distal stones, uretoscopy. Look at the ureters from the inside. And this makes sense. If you're going to put a scope in through the urethra to get to the ureters, it should be pretty close to the opening. Whereas if it's close to the renal pelvis, you may not be able to reach it with the scope. Lastly, if the person is septic, that is, you need emergent decompression of the GU system because of the stone, you can do either a nephrostomy tube. This is generally done for proximal disease, or stenting for distal disease. Okay, so we can see how much more complicated it gets when you actually have to manage in real life. What I want you to feel, regardless, the pattern is, if small, get it out on its own. If it's really big, do surgery, and if it's somewhere in between, break it up. But even after you get that stone out, you're not done. The person needs to strain their urine, because you want to identify the type of stone that it is. Because once you know the type of stone, you'll be able to modify risk factors. And even then, you're not done, because while you're modifying risk factors, you come back in 6 weeks for a repeat screen. If it's positive, you continue to strain. If it's negative, you can stop. Before we move on to the type of stones, I just want to review it one more time. Patient presents with colicky flank pain that radiates to the groin. The best diagnostic step is non-con CT, and the treatment is going to be based on the size. Most of the time, it's just get it out with fluids and pain meds. Otherwise, you might need a little bit of help, calcium channel blockers, alpha blockers, or you might need to break it up. Lithotripsy equal to uretoscopy. Okay, let's talk about the types of stones and their risk factors. So we want to be able to identify the stone, whether it is radio opaque or loosened, and what the risk factor is and how you modify it. Knowing that because kidney stones form, they precipitate out. And if you have lots of volume, as you have fluid, you dilute the urine and make it less likely to precipitate out a stone. So maintaining hydration is crucial, both for the management and the future prevention. most patients are going to recur with their kidney stone, even with risk factor modification. The most common kidney stone is calcium oxalate. This is a radio-opaque stone and accounts for about 80% of stones. The risk factors are, not surprisingly, increased calcium in the urine and increased oxalate in the urine. You can modify these risk factors by giving thiazide diuretics and then by changing the diet. Oxalate comes in the form of protein. You want to decrease oxalate consumption, which means decrease the amount of red meat, and increase citrate. Eat more fruits and vegetables. Now there are other things that you can do, but I'm going to only do the high yield ones. The second most common is the struvite stone, magnesium, ammonium, phosphorus. This is opaque. It is caused by UTIs like Proteus, which have urea splitting activity. And so whenever you have a UTI, manage it aggressively. And unfortunately, these stones are huge. They're the staghorn colliculi. They're just big and they're all up in the kidney and they don't pass on their own. And if you have a kidney stone in the kidney, it's more likely to precipitate more stones. So the only thing you can do here is actually surgery, where you remove all of the stone burden and then prevent the UTIs from causing any more of these stones. Uric acid stones are radiolucent, and they are caused either by gout or tumor lysis. Now, most patients who have uric acid stones actually have no reason for them, but you can modify gout and tumor lysis by giving allopurinol to gout. And if you forgot to prophylax them against tumor lysis syndrome and they have uric acid stones, you can use raspuricase. Again, the dietary change is also good for gout. Avoid alcohol, red meat, and seafood. And the last one you need to know about is cystine stones. They're radiolucent. It's a genetic disorder. You won't see it. Okay. Be able to spot it, diagnose it, and treat it. And then after you figure out what type of stone it is, know how to manage the risk factors. That's kidney stones.